Hi students, let's discuss all important aspects of iron deficiency anemia today. Now, what are all the important points you need to remember under iron deficiency anemia? Number one, that this is a cause of nutritional anemia, right? Nutritional anemia due to deficiency of iron. Next, it is the most common cause of hypoproliferative anemia characterized by low reticulocyte index. So, hypoproliferative anemia. Now, another important aspect is how will you evaluate a patient of anemia? So, what are the clinical manifestations you expect in a patient of anemia? That the patient will come to you with the complaints of, yes, fatigue. Yes, patient will be tired, right? Fatigue, tiredness. Patient may complain of malnutrition, right? Dizziness, palpitations. All these features are secondary due to the deficiency of hemoglobin. So iron deficiency will lead to defect of hemoglobin, right? So there will be a deficiency of hemoglobin secondary to iron deficiency, right? So that is very important, that iron is required for the formation of heme component of hemoglobin. Because iron is deficient, there is deficiency of hemoglobin, and thus the oxygen carrying capacity of blood decreases. Because your body will not get oxygen, your body will not get energy, and the patient will complain of tiredness, fatigue, dizziness, right? So this is very important, how the patient will present to you. Now, one important nail finding that can be given to you is koilonychia, where you will see pale nails, right? So there will be paleness of skin also due to deficiency of hemoglobin. So pale skin along with spoon-shaped nails will be seen in koilonychia, that is secondary to, yes, severe iron deficiency anemia. So patient complaints will be complaint of fatigue, tiredness, dizziness, malnutrition may be there in the patient, palpitation, paleness of skin. Along with that, they can give you a nail finding of koilonychia. Now, what nail finding can they give you in a vitamin B12 deficiency? We will study under megaloblastic anemia. They may show hyperpigmentation of knuckles. So hyperpigmentation of knuckles, if in your fingers it is given hyperpigmentation of knuckles, that is a finding pointing towards B12 deficiency. Along with that, they can give you, yes, they can give you this red colored tongue, right? So that is will be secondary to B12 deficiency. So very important are these findings. So spoon-shaped nails, can you see spoon-shaped nails? And secondly, pale nails is seen. So this is koilonychia, which is seen in severe iron deficiency anemia. Very important, severe iron deficiency anemia. Now moving on to the next, let's have a look at the microscopic examination. Very important. Let's have a look. So you can see here. Now you can see here, this is the image from your Robbins where severe hypochromia is seen. Normally the central pallor is only 1/3 of the total diameter, whereas here you can see it is more than half. So when it becomes more than half the central pallor, it is called as hypochromia. देखिए खाली खाली cells हैं बिल्कुल. So this is severe hypochromia. Along with that, some abnormal forms of RBC such as pencil cells can be seen. So what is the microscopic examination, or I can say PBF examination in a patient of iron deficiency anemia? Very important. Number one will be microcytic hypochromic RBCs will be seen. Very important. So this is one of the important differential of microcytic hypochromic RBCs. What do you mean by microcytosis? Yes, the normal MCV of RBCs is about 80 to 100 femtoliter. So what is the unit of MCV? It is femtoliter. So it is 80 to 100 femtoliter. When it becomes less than 80 femtoliter, right, this is microcytosis. Another way which can be used in order to assess the size is that the normal size of RBC is about 7 micrometer in diameter. So when it becomes less than 6 micrometer, it becomes a microcytic RBC. And usually a macrocytic RBC is more than 9 micrometers. So this is one of the way to analyze the size of RBC. But obviously in laboratory, this is the best parameter which is given in you by your machines, MCV, where you find out the mean corpuscular volume. Normal is 80 to 100 femtoliter. In a case of iron deficiency anemia, because there is microcytosis, your MCV will be less than 80 femtoliter. So students, what would be the finding? That so one, the clinical manifestations we have already discussed. Next is laboratory manifestation. So you will see, yes, definitely hemoglobin will be low. Right, number one was that the heme component is deficient due to deficiency of iron, and hemoglobin will be low, and that is why the patient will have symptoms such as fatigue, tiredness. So hemoglobin has to be low. Along with that, next finding you will try to look at is MCV. So I will see my MCV and analyze it on the basis of the mean corpuscular volume. If MCV is less than 80 femtoliter, I will put it in the category of microcytic hypochromic anemia. Very important, right? Very important. And what are the four important differentials of microcytic hypochromic anemia, students? Quickly we can, if you remember our mnemonic, it is SITA. So it is sideroblastic anemia, number one. It is sideroblastic anemia. Number two is iron deficiency anemia. Then thalassemia minor. And last is anemia of chronic inflammation or anemia of chronic disease. Now students, you should know how to differentiate each of these. Very, very important. How will you differentiate the four important causes of microcytic hypochromic anemia? So MCV will be low in all these conditions, right? So we will also discuss the difference between them as well. But let's concentrate on the microscopy. So I hope you are able to find out that the size of the RBCs will be smaller than the size of the surrounding lymphocyte. Suppose there would have been a lymphocyte like this, right? So this would have been smaller than the surrounding lymphocyte, and the central pallor will be more than half. Central pallor will be more than half. Now, along with that, you can see some abnormal forms of RBCs such as pencil cells. So all these manifestations are clear, I hope, on peripheral blood film examination, right? So in laboratory finding, what will happen to hemoglobin? Yes, obviously it is iron deficiency anemia. So hemoglobin has to be low. MCV will be low. Definitely, it is a very important differential of microcytic hypochromic RBCs. Next, MCH will be low. Right, these are very important. What will happen to reticulocyte count? Retic index, that will be low. This is a case of most common cause of, yes, hypoproliferative anemias. Right, so moving on to the next. Moving on to the next, we will see. Right, so what will happen to RBC count? RBC count will be low. Right, RBC count will be low, and that is a very important point to differentiate it from a case of thalassemia. In iron deficiency anemia, your MCV will be low and RBC count will be low. But in the case of thalassemia minor, yes, it is an important differential of microcytic hypochromic RBCs, but RBC count will be normal or slightly increased. A very important point. So in a patient of thalassemia minor, right, the RBC count will remain normal or slightly increased. Now let's come to an index of Menzer index. Right, so how do you calculate it? You calculate it by MCV by RBC count. So both the conditions, our MCV is decreased, but based on the RBC count. In iron deficiency anemia, this RBC count is also decreased, and thus Menzer index will be more than 13, very important. Whereas in case of thalassemia minor, your MCV is low, definitely it is a cause of microcytic hypochromic anemia, but the RBC count will either remain normal or it will be increased. Then can I say that the Menzer index will be less than 13? This is a very important differential. In order to differentiate iron deficiency anemia from thalassemia minor, you need to see the RBC count. Now let me quickly come to what will happen to these parameters. Let's have a look. Very important. Serum iron will be low. Now ferritin is the storage form of iron. Because serum iron is low, the storage also doesn't have much of iron, so serum ferritin will be low. So this is the most sensitive tool for the diagnosis of iron deficiency anemia. What will happen to serum transferrin saturation, students? Yes, transferrin saturation will be low. Right, transferrin saturations will be low. Now, if you remember the molecular level of iron absorption, we had already discussed that what will happen to transferrin receptors. We'll also study today that normally in iron deficiency state, what will happen? There is a element, this iron responsive element, which is protected by a protein called as aconitase. So normally aconitase protects iron responsive element from the action of RNases. Thus RNases are not able to act, it will be functioning well. Transferrin receptor mRNA will be functioning well. There will be increased concentration of transferrin receptors, and thus the total iron binding capacity will also be increased. So what will happen to TIBC? Very, very important, students. You cannot miss these points. Let me just tell you the most important points. Hemoglobin will be low, MCV will be low, MCH will be low. Along with that, increased TIBC, right? So along with that, increased TIBC will point towards the diagnosis of iron deficiency anemia, whereas in anemia of chronic disease, what will happen is, yes, this first, the serum ferritin will be increased. Even if in a case of, yes, the serum iron may be low, but serum ferritin is increased, very important. Number 2 will be what will happen to TIBC, because serum ferritin is increased. TIBC will be low. So TIBC will be low in a case of anemia of chronic disease. And this is a very, very important question. So all these are important questions, right? You cannot miss out on any of these points. Now let's come back in the platelet count. So relative increase in the platelet count. So relative case of thrombocytosis can be seen. So I hope all these findings are clear to you. Now moving on to the next, we need to know about the iron absorption. Very important. Iron absorption is very, very important. A lot of questions are asked. So we'll quickly have a look here. So here you can see this is the heme iron, and another form can be non-heme iron as well. So heme iron, right, is better absorbed. Number 1, it is better absorbed. So in non-heme iron, it is the Fe3 plus form, which needs first to be converted into Fe2 plus form. That is converted. So definitely you need a reduction here. So the enzyme will be duodenal cytochrome B reductase. Very important. This is a question. Duodenal cytochrome B reductase will be reducing it to Fe2 plus form, and this Fe2 plus form will be transporting across the transporter, that is the divalent metal transporter. As the name suggests, it is not specific for iron, but it can also transport other divalent metal cations such as cobalt, zinc, manganese, right? So all these can also be transported across this transporter. So the function of these two is clear, right? Now once iron needs to be stored inside these duodenal enterocyte. Now what is the most common site of absorption of iron? If you remember the mnemonic, we have discussed a multiple number of times in our lecture. So IFB, right? So you can remember the parts of small intestine comes first to be duodenum, followed by, yes, jejunum, and then ileum. So similarly, you can remember this mnemonic IFB. So iron gets absorbed predominantly in the proximal part of small intestine, that is duodenum. Folic acid gets absorbed in the jejunum, and vitamin B12 gets absorbed in the ileum. So if any disease of duodenum, if you remember celiac disease, so if they give you a complete scenario of a patient suffering from gluten sensitivity or celiac disease, right, what will be the main kind of anemia that will be seen in these patients? Yes, because it is involved with a defect of duodenal absorption, malabsorption. There is deficiency of iron, and thus you will see microcytic hypochromic type of anemia in a patient of celiac disease. So I hope it is clear. Now ferritin is the storage form, and when this iron needs to get transported across the basolateral surface, right, of enterocyte, it gets transported with this ferroportin. So once iron comes out, it needs to get attached to which protein? By transferrin. It gets bound to transferrin and is transported into the erythroid marrow, where it will be utilized by the premature erythroblast, basically the normal blast, to form the mature RBCs, right? So transferrin is the form which leads to transport of iron, right? But ferroportin is the protein which helps in the transfer of iron from the storage form of ferritin into the outside, into the circulation across the basolateral membrane of the enterocyte. Now ferroportin is under the inhibitory control of hepcidin, which is released from hepcidin. So hepatic source is there. So liver is the source of hepcidin, which inhibits ferroportin and thus doesn't allow the transport of iron from the enterocyte to outside of the circulation. So what happens in anemia of chronic disease? Very important. Let's have a look here. So in case of anemia of chronic disease, yes, anemia of chronic disease, liver leads to increased concentration of hepcidin by basically interleukin 6. Now this hepcidin will inhibit the transport of iron, by inhibiting ferroportin. So hepcidin is increased in anemia of chronic disease, because of which the iron is not able to get transferred across the basolateral membrane, and thus the ferritin here will be increasing, the storage ferritin form will be increasing, but the serum iron will be low. So this is a very important cause. But when we will be dealing with anemia of chronic disease, we will discuss that this mainly characterized by normocytic normochromic type of RBCs, and in less number of cases, about 20% of cases, it can also show microcytic hypochromic type of RBCs. So I hope this iron metabolism entire thing is clear to you. Yes. Now see, this is the bone marrow. So number one, we have already done the lab analysis. Lab analysis is done along with the clinical features. Now moving on to the next, we have seen the PBF findings. And third will be the bone marrow aspiration. So what will you see on bone marrow aspiration? Because you can remember iron deficiency anemia is characterized by microcytic RBCs and PBF. Even on bone marrow aspiration slide, you will see micronormoblast. So let me zoom into the image and you would be able to see that they are small in size, yes, and along with that there is fraying of cytoplasmic borders. So they are very, very small in size. They are micronormoblast. Along with that, you can see some cytoplasmic basophilia because of defect of hemoglobin part. And along with that, you can see fraying of cytoplasmic border. So these features are seen in a case of micronormoblast compared to a case of megaloblastic anemia, where you would see megaloblast. That we will discuss when we are dealing with megaloblastic anemia, right? So this is bone marrow aspiration. What stain will you apply? Pearls or Prussian blue stain. And on this stain, because there is a deficiency of iron, so that will lead to, yes, depending on the severity of iron deficiency, there will be deficiency of iron on pearls on Prussian blue stain. In fact, the application of pearl stain on bone marrow aspiration for detection of iron deficiency anemia is the best or the gold standard method for the diagnosis of iron deficiency anemia. I hope till here it is clear to you. Okay, so let me just, one more thing which is left is Plummer-Vinson syndrome, which is characterized by a triad of clinical manifestations. Yes, what will be there? There will be dysphagia due to the formation of this post-cricoid web, right? Along with that, there will be iron deficiency anemia and features of atrophic glossitis can be seen. And thus, this triad leads to the characteristic Plummer-Vinson syndrome. Right, students? So till now, we have discussed about the number one, laboratory analysis. Hemoglobin will be low. MCV, MCH will be low, retic index will be low, serum iron will be low, ferritin will be low because this is a storage form, best sensitive tool for iron deficiency anemia. Transferrin saturation will be low, right? And TIBC will be increased because in iron deficiency anemia, what will happen is this aconitase will be protecting the iron responsive element and thus increased mRNA formation for transferrin receptor, and thus increased transferrin receptor formation leading to increased total iron binding capacity, right? So all these are important questions. On PBF, what will you see? You will see microcytosis, hypochromia, along with that pencil cells, few target cells, right? Along with that, increased platelet count can be seen reactive secondary to iron deficiency anemia. Now, along with that bone marrow aspiration we have seen, what will you see? First, you will see deficiency of iron, which is the gold standard on pearls of Prussian blue stain. So blue. So you can remember normal iron stores are blue on the stain, but here there will be a deficiency. Along with that, very, very important finding, micronormoblast are seen, which are characterized by very small size of normoblast along with cytoplasmic basophilia and fraying of cytoplasmic borders. Now last question, students, we have already discussed what will happen in iron deficiency anemia, right? What will happen is that the iron concentration will be low and the aconitase will be protecting this iron regulatory element, because of which it will not be degraded by the RNases, and thus the transferrin mRNA will be normal or increased in number, and thus transferrin receptors will increase, increasing the TIBC. So transferrin receptor 1 iron responsive elements will increase. mRNA concentration and synthesis will also increase. So I hope till here it is clear. Now let's have a look quickly. Tell you the differences between the four important causes of microcytic hypochromic anemia. So in iron deficiency anemia, serum iron will be low, serum ferritin will be low. Whereas in case of anemia of chronic disease, even if ferritin is high, but the ferroportin is not allowing the transport of iron across the basolateral membrane, and thus the serum iron will be low. Very, very important, a frequent asked question. Percentage transferrin saturation will be low, because why? Because the serum iron is low, so transferrin saturation will be low. Normal it is about 33%, right? About 1/3 of the transferrin receptors are saturated with iron, but here it is further decreased. Now TIBC, what will happen? It will depend on the concentration of ferritin, right? So it will be depending on the concentration of ferritin, right? So TIBC here will be increased because the ferritin is low, so it is inversely proportional to ferritin. And we've already discussed the regulation of transferrin receptors. So because here the microRNA of transferrin receptors is increased, and thus transferrin receptors are increased, TIBC will be increased, ferritin will be low. Whereas in a case of anemia of chronic disease, TIBC will be decreased. Now serum transferrin receptor by log ferritin will be higher than 1.5 in iron deficiency anemia, whereas lower in case of anemia of chronic disease. Now very important difference in between iron deficiency anemia and thalassemia trait is the RBC count. So MCV will be low in both, दोनों में कम होगा, लेकिन RBC count iron deficiency anemia में कम होगा, इसलिए जो आपका रेशियो है वो बढ़ जाएगा more than 13, whereas in thalassemia trait it will be less than 13 because the RBC count is normal or slightly increased. Now nothing will happen to iron profile in case of a thalassemia trait. So ferritin, iron, everything will be normal, at least in a trait patient, right? But in a major patients, iron and ferritin will be increased. Now moving on to the next, sideroblastic anemia. Now we will be discussing about sideroblastic anemia in our next slide. So last we will see the sideroblastic anemia. So what happens in sideroblastic anemia? Basically it is a defect of heme. So succinyl CoA usually gets lead to the formation of this ALA, right? So with the help of ALA synthetase. Now this ALA in the presence of dehydrogenase will be converting to porphobilinogen. This porphobilinogen will be getting converted into protoporphyrin in the presence of the enzyme ferrochelatase. So that will combine with iron and lead to formation of heme. So what happens is when there is a defect, suppose inherited form where there is a defect of this enzyme ALA synthetase, that leads to an inherited form of sideroblastic anemia. There could be a defect of the enzyme ferrochelatase, there could be a deficiency of copper, right? Copper deficiency, lead poisoning, drugs such as isoniazid, pyrazinamide. So all these will lead to a defect, right? That will be leading to a defect of heme, right? So because this iron will be in excess, because this is not able to combine with protoporphyrin now to form the normal heme. So what will happen is, because there is a defect at these levels, the iron level will increase. So serum iron will be high, even the serum ferritin level will be high, right? Transferrin saturation will be high as well, and thus the TIBC will be low. Now how will you see this sideroblast on bone marrow aspiration? There can be 3 grades, 1, 2, 3. So in one grade you will see that there is iron granules, right, siderotic granules in the cytoplasm, but they will be less than 5. So less than 5 iron granules will be there in the cytoplasm. Whereas in grade 2, right, in grade 2 there will be more than 5 siderotic iron granules, but not in the perinuclear position. In grade 3, yes, there will be more than 5 siderotic iron granules encircling more than 1/3 of the circumference of the nucleus. These are the ring sideroblast, right? So normally you will grade 1 sideroblast in your bone marrow, that is not an issue. But when it becomes to such a level where 5 coarse siderotic iron granules encircle more than 1/3 of the circumference of the nucleus, they become abnormal, pathogenic, that are the ring sideroblasts, right? So these findings will be seen in the bone marrow in a case of sideroblastic anemia. So till now we have discussed about iron deficiency anemia. How will you differentiate it from anemia of chronic disease? Based on the serum ferritin and also the TIBC level, and it is because of the increased release of hepcidin from liver, right, in cases of underlying chronic inflammation, cytokines such as interleukin 6. So liver is the source of hepcidin, which will inhibit ferroportin and thus does not allow the transport of iron from the storage form of ferritin into the circulation, right? So that is anemia of chronic disease. Sideroblastic anemia we discussed. We have also discussed the appearance of various sideroblasts on bone marrow aspiration and thalassemia trait. We have discussed about the Menzer index, right, and how can you differentiate these 4 important causes of microcytic hypochromic anemia, right?